Dr. Boer's up
Wait a
first.
minute. Dr. Vora. Univate.
Good early evening.
Stay on the end.
Ronald Moore, I'm a pain medicine physician. I've been practicing here in Mississippi for 25 years. I'm going to try not to repeat what's been said. I'd like to make a few observations and concerns for your consideration. I think one of the crux of the issue, one of the problems with this, as it is written, is that we've taken the CDC guidelines. That was our basis. The CDC guidelines are specifically only for primary care physicians. It says it on the first page of the CDC guidelines. And we have now spread that to include all physicians in all situations. And in doing that, I think that we're going to do some of our patients an injustice. With acute pain, for a primary care physician, a 7-day limit on opioids is reasonable. If somebody turns their ankle, if somebody twists their shoulder, they probably don't need 3 or 4 days of rest. But someone that gets hit by a car, crushes her pelvis, someone that has multiple vertebral fractures, someone that's just undergone a complex spine surgery, their expected time to heal is much greater than 15 days. And in those patients that I care for, the key to caring for those people is early mobilization. And if you are not able to control their pain, those patients will not be mobilized. They're going to become deconditioned, they're going to become contracted. And I'm unsure at this point what happens at day 15. Their pain doesn't go away at day 15 if they've had this. So what happens? What do you tell the patient? I'm sorry. You know, lay in bed until you give up. I think that you have to have an avenue where you can justify in these patients that have significant injuries or significant surgeries, the continuation of those medications within their expected time frame. And I think another unintended consequence is if you read this literally, there is no more chronic pain in Mississippi, because you define chronic pain as someone that's been on an opioid for 90 days. That's a chronic pain patient in this. Well, under this, you can't get to day 15. How can you possibly get to day 90? What happens between day 15 and day 90? So I don't understand how we're going to manage these patients. Just because someone's on opioids doesn't mean that they're an addict. If someone has a true medical need, those patients should be able to be cared for. I think another unintended consequences is that you're going to see increased rates of surgery. Right now, when I see patients with acute radicular pain can be excruciating if any of you had it. Right now, we can control their pain and try to control their pain with anticonvulsants and opioids in an attempt to get them better through injections and physical therapy. Well, at day 15, I can't cure them in 2 weeks, nobody can. At day 15, if we can no longer control their pain, those patients aren't going to be able to tolerate therapy. They're not going to be able to tolerate treatment. They're going to go straight to surgery. And I think that's going to be an unintended consequence. We have to be able to care for these patients and try to avoid surgeries in these patients. And I think I would like to touch on the benzodiazepine issue. I get where you're all going. Taking out some by taking out benzodiazepine, they call it the Texas Trio, the Holy Trinity, which is an opioid, usually oxycodone, Xanax, and Soma. And certainly as pain physicians, we strive to minimize dosages of benzodiazepines and opioids. However, that said, a complete ban is unjustified. I'll give you an example. I have a young man that I care for. He's a TA, incomplete paraplegic. He has spasticity so bad, the spasticity kicks him out of his chair. And the only way we can control it is with a combination of baclofen, Xanaflex, and Valium. And this young man was doing a transfer. He fell out, shattered his shoulder. Well, what do? and has acute pain, which I expect is going to last for 6-8 weeks because of her shoulder. And now I'm left with Sophie's choice. Do I allow you to suffer in pain because you shattered your shoulder? Or do I allow you to have spasticity so bad that you can't sit in your chair? There are clinical indications for the combination of these medications. And I think we should also not forget that patients with mental illness have pain as well. One of the known complications of chronic pain is anxiety and depression. They live together, and they feed off each other. Patients with chronic pain get depressed and anxious, and their anxiety makes their pain worse. And you have to treat both ends of that. If you don't treat both, you are not going to be able to adequately control that patient's symptomology. And I don't think that patients with mental illness should be second-tier citizens when it comes to pain control. I shouldn't have to take a patient that's had surgery off of their Xanax so they can have post-operative pain medications, because what's going to happen is their anxiety and their kinesiophobia is going to go through the roof, and they're not going to progress through rehabilitation because the mental illness is out of control. Again, I think it's an unintended consequence, and I think a ban, although well-meaning, is a disservice to our patients. My time is up. Thank you very much.
Before you're getting up and clarifying, you seem to think that we're limiting a 14-day supply.
Yes, sir.
You can give a 14-day supply, and then you see the patient back, you can give another 14 days. Okay, so we're not saying only 14 days. That's number one. Number two, we do make an exception. If you're on chronic benzodiazepine therapy, you have an acute injury such as a broken shoulder, you can prescribe benzos with opioids for a reasonable period of time.
It says a very short period of time.
Well, maybe we need to find that further.
See, for example, my spasticity patient they've been on benzos forever.
Yeah. But they should be on opioids forever.
Hopefully not, but
Okay.
if he develops a chronic pain syndrome, we're like,
Individualized. Thank you very much for your answer. Now we have the Comprehensive Pain Center of Mississippi, Dr. Vance.
Speak really loud anyway, but I'll put this on for yourself. So I'll give you a little background about me, just so you know. I'm one of those pain clinics that everybody wants to send those patients to. Just some of my background, so you know, I was anesthesiologist here in town, board certified in that. I did a fellowship in pain management at MD Anderson Medical Center. So I deal with both cancer and non-cancer chronic pain patients. And some of the rules, I agree, everybody beat it to death about benzos and opiates together, but some patients are not going to be able to get off of either one of them long term. It's just not realistic. I have neuropathic pain patients. I have patients with multi-level surgeries to their spine. They can hardly stand upright that are on pain medication long term. I've used up every kind of known muscle relaxant in the world. I have to use Valium occasionally on them. I have patients with neuropathic pain so bad that we use methadone out of my clinic for chronic non-cancer pain. There are conditions where that's appropriate. And I've treated cancer patients with it here in town. We're very strict about the patients that we had. I looked at my numbers this morning. I've seen 12,282 patients since 2008 when I opened my doors. I have about 1,000 that I see all the time on a regular basis. Some of them are on, and a lot of them are on chronic opioid therapy. Obviously, I try not to write benzos. I like to share that responsibility with psychiatrists. I have soldiers with PTSD and their leg gone, and there's not a possibility they're not going to need a long-term opiate for their neuropathic pain, because I can't cover them with every spinal cord stimulator, and I can't inject away everything that's available, in the United States. Every pain condition that we have, there's not always an injection to do. There's not always a procedure to do. I'm still stuck with the idea that I'm in 2017, there's not an answer and not a medication that's not an opiate for every problem that we've got. So I think for pain physicians like myself that went through the training to get to where they are, there should be a carve out for some of those medications, and there should definitely be some exceptions, especially when it comes to the daily morphine equivalent dosing. I think for family practice it's appropriate. I think for a lot of the patients I see, not necessarily. I think that if we're gonna have a patient on a benzo and an opiate at the same time, that it's appropriate that maybe a psychiatrist share that responsibility with me. So you do have a two patient prong that's looking at that kind of patient to make sure. And I would hope that, you know, in part of the recommendations that y'all are throwing out, that we want to pull methadone as a chronic, non-cancer pain option off the table. I think that there's a subset of population. I have 18 patients right now. I can describe some of them to you. I've got a guy with Crohn's disease. He's had it since a teenager. He's in his 50s now. He's had every major joint in his body replaced except for 3. He's trying to hold off on surgery. He's very high functioning. He's a film director. He has to use some methadone. I have a lady, and he's very high functioning when he uses it. He doesn't have these peaks and valleys that you're going to get with the short-acting opiates that only last 3 to 4 hours at a time. He'd already gone through all the other long-acting medications and maxed them out. They were not a possibility. We've weaned him off. We've given him drug holidays on his own volition. And yet we still are stuck. I do experimental things that insurance won't pay for some of my patients. We do stem cell therapy. We do PRP. Insurance isn't covered. I do ketamine infusion therapies for some of these neuropathic pain states. But insurance won't cover that either. And so not everybody's going to be able to get to those kind of things right now. But my only issue and my only hope and only thing that it had been beat to death at this hearing already today is that I would hope that at least you might do a little carve out for a chronic pain physician such as myself that has to use methadone in his practice from time to time with select groups of patients. That's all I have to say though.
I think our idea with the methadone was that if somebody got stuck there, we would send them to you and let you reaffirm that, this is what they're gonna have to have.
And that would be okay. I just saw it was just a blanket statement that we're gonna pull methadone as a chronic pain use option. And I, it does have the stigma of addiction and heroin use. And a lot of my patients don't want it. But the other problem is a lot of those patients are disabled and they're on Medicare or Medicaid. They don't have, and the formularies for those groups are getting tighter and tighter and tighter, and they can't afford a trade-named Extemsa, abuse deterrent medication when it's a tier 4 and they're having to pay $500 or Blue Cross won't cover it at all. And sometimes I'm stuck with it just on the sheer cost issue. But I have to be very careful with it. It's a dangerous drug. I'm not telling you it's not. But I'm very strict with my patients. We have pill counts. They come in every 2 weeks. We make sure until they get to their standard dosing on it. And I had patients that were willing to come with me today, but I just didn't hear this was open to the public. But that would tell you how much better their life is when they had that option. The other thing about Suboxone we were talking about a minute ago, that molecule has great options for us in the long run, and I use it for chronic pain patients. And they're using that molecule for chronic pain too, not just for addiction. So I want to make sure that the buprenorphine folks don't just get thrown in the baggage you're an addict if you see buprenorphine coming up, because there's 4 other products on the market right now where we use buprenorphine for chronic pain, not just for addiction treatment. So thanks.
Appreciate it.
Yes, sir.
Now, from North Mississippi Health Services, Dr. C.K. White.
Move to the corner.
Good thing.
I always hated having a W in my name. I always ended up this way. I'm glad. But the last will be first. Thank you very much. Much of what I was going to cover has been covered, and I will be brief and I'll try to be precise. And I will be first of all grateful for what you're trying to do, and grateful for your patience to listen to a lot of these concerns. Change is hard. Change is scary, and change is necessary. And that's what we're going through right now. We, in my opinion, are reaping the benefit of exactly what several people alluded to earlier, 12, 15 years ago, when pain was a bad thing, and it is a bad thing now, but it was something you were graded on, and you were taught to treat it not to the point of pain relief, but to the point of happiness, because we wanted good reports from all of our patients, and that's what we did. And I think earlier you made the point that a lot of these, the bulk of some of our younger practitioners out there were trained that way. The problem is, and as you all have seen right now, when something comes in this big a bulk and this big a package and it has this many changes in it, it affects every single specialty, every single area, and every single group a little bit differently. I think the thing, and I'll be philosophical rather than instructional, because we've already been through most of the things that I wanted to point out. I represent about 875 physicians up in North Mississippi through a clinically integrated network that's up there, and through North Mississippi Health Services, where I'm the Chief Medical Officer. All of the questions and all the concerns they came to me with are the same things that you've heard from each of the individuals here. And what I would say from a philosophical standpoint is I think that everyone in this room, on both sides of this table, has the same thing in mind. We want to take care of our patients. We want to do the very best thing for our patients. I think the hard thing to do is to come up with a set of rules that allow us to do the right thing for the right patient in the right dosage, the right length of time, every time, and call it individual treatment. So your task and have undertaken quite a chore. It's very, very difficult. But what I would say is that in conjunction with the people that are willing to sit here for 4.5, 5 hours so that they can get their point across, and your willingness to sit there and to allow us to do this shows that there's a nidus that we can reach a consensus and make this better. There's no question the opioid crisis has to be approached. There's no question that changes have to be made, and yes, they're painful. So again, from a philosophical standpoint, what I would say is that what we really want to do here is not take, if you listen to a lot of the tone that you've heard, is fear. Fear that somebody's not going to be able to do for their patient what they feel is necessary. Fear that they're going to be punished for doing what they think is right for their patient. Fear that they're not going to be able to take care of their patient. That's a lot of the emotion that I've heard standing here today. So what I would say is that what we want is the ability to know that we can treat our patients within the rules and the guidelines, and that we can individualize treating our patients. And if somebody comes calling to check on us, if there's a pain doctor using methadone, there's not many of us that can argue with it. If I'm using methadone, you need to check me. There are levels of care that need to be established. I think that's what you all have tried to establish here today, some basic rules for us to work with. I'll just finish with one comment that hit me as I was standing there, and Mr. Dowdy, I didn't, where'd he go? But what we want to do right now is we don't want to handicap and handcuff good doctors who are compassionately and caringly trying to take care of their patients. What we do want to do is handicap and handcuff those people that are doing it in the wrong sense. And I think that's what you're charged with, is some way to identify the two. And with that, I will certainly answer any questions, but I thank you for your time and your patience, and for everyone that stayed this long and get a free cigar from Dr. Miles. But don't smoke it and don't inhale it.
Thank you, Dr. Next speaker is from the American College of Emergency Physicians, and it's Dr. Sterling Natty Jones McDonald.
It's just me.
Everybody gets 2 minutes. No.
Just me. Hi, I'm Sarah Sterling, the president of the state chapter of the American College of Emergency
Speak up, please.
Thank you for having me here today and for taking the time to hear all of our feedback on this important issue. And thank you for addressing the Mississippi ASAP. Applaud your efforts to address the opioid epidemic, specifically the healthcare crisis that we're facing as a nation. We do, however, have some specific objections to the requirements as they stand. Specifically, we would ask you to reconsider the requirement for the PMP to be checked for every opioid prescription, specifically in the ED for acute pain. We know acute painful conditions, sometimes checking the PMP will not change our management. We know if a patient has a fracture, even if they have a lot of hits on the PMP, they may still appropriately need a short-term prescription for opioids. We feel that checking the PMP could impede patient care, patient flow for busy physicians in the ED. In smaller EDs, you did say that you could have a surrogate check the PMP. You didn't necessarily, as a physician, have to do that. In smaller EDs, they might not have the administrative help that some of us do in larger EDs or hospitals. So I do think that that could burden emergency physicians and ultimately impede patient care and patient flow, and might encourage physicians to just not prescribe those narcotic prescriptions when they're otherwise legitimately necessary. Research has shown that prescriptions written in the ED are more likely to follow CDC guidelines compared to non-ED prescriptions. They're typically written for shorter dosages, shorter durations, and most importantly, research has shown that they're less likely to lead to chronic lung disease than in non-ED settings. Finally, as other physicians have noted, there is concern that these requirements as they stand will lead to increase in ED visits, particularly in cases where, although acting out of an ED, in general, Mississippi ACEP supports a 7 to 14 day prescription for opiates for acute pain. That does put a burden on our clinic physicians to see those patients that will require a refill after 14 days. If they're unable to meet those patients' needs, just because now they're having to increase in patient flow and need to see their patients more frequently potentially, there is some concern that fallback will allow them to manage those patients that their primary physician just can't see because they're too I think everything else has been addressed by the other speakers, the other 27.
Our next speaker will be Dr. Michael Mansour from the State Medical Association.
Thank you, Dr. Miles. I'm Mike Mansour. I'm a cardiologist at Greenville. I'm speaking from the State Medical Association. Just a couple of brief points. One is that hopefully we can look at this, and we applaud everyone's effort in dealing with this opioid crisis, as everyone said, and knows we have to deal with it. We hope it can be dealt, I personally, personal comment, I hope it can be dealt with this in two aspects. One are the people who have been chronically on pain medicines and need help in a certain way, dealing with their pain, getting off those medications, getting in treatment of chronic therapy. The other are people who have never been on pain medicines. And hopefully we can find better ways to treat those people so that they do not become dependent on opioids. So, and looking at it in two different directions. As a cardiologist, I rarely prescribe pain medicines, and many physicians seldom prescribe pain medicines. We're concerned about the rules and not compromising patient care with some of the regulations that may be inadvertent in the whole situation of dealing with opioids. And specifically, we look at Rule 1.4 and pages 26 and 27, where it calls for a personal examination of patients. And we've heard this from a couple of speakers ago about the situation where you may be on call. It's also in Rule 1.11, and it seems to lump all prescription medications in with narcotic or addictive potential medications. So I would be concerned that we would be lumping in antihypertensives, antibiotics, things that you might prescribe on call. You may be covering for another physician. It may not require an examination if that patient is in a continuum of care where they have access to their physician or to communicating with their physician. And so they're in a continuum of care, but not necessarily a direct physician-patient relationship where you have to examine that patient. And this would be particularly important in a lot of situations, some of them you've heard, but we want to make sure that those people will not be compromised, especially in rural areas of our state. Some people take, they have to arrange for transportation to the physician. It takes 3 days notice to get transportation. So in that 3-day time, they may have serious compromise in their health when an elderly patient with lung disease could be on an antibiotic. They may end up in the hospital in 3 days. A pregnant woman with a UTI may miscarry in 3 days and not be treated. in different situations, a mother at home with small children, one is sick, the next one becomes sick, she can't take them. And it just presents different issues. So we would hope that the board would look carefully at what is called legend medications, so that all prescriptive medications are not lumped into pain medications, which is my understanding. The purpose of the governor's task force is to deal with pain medication. And we all understand the good practice of medicine, but there are two different issues there. And sometimes it's not feasible, and sometimes it's not good medicine to actually personally see the patient face to face, as long as they're involved in the continuum of care and they have access to be able to communicate information.
If you're on call for somebody else, it's never intended to cause a problem. May not be clear enough, but we'll make it clear. And now, for the last speaker, Dr. Carol McLeod.
I'm going to be real brief. I serve on the governor's task force, Dr. Miles, on some of this, and a lot of this was intended consequences, some of this was unintended consequences. One of the things that I think is real unintended is on the 7-day acute pain for the PMP, and we went back and forth on this even in the governor's task force. And I think for surgical patients, a lot of times the PMP for a 7-day prescription is going to be, and I've listened to a lot of my orthopedic colleagues, and even for longer, acute pain could be burdensome if the PMP was allowed to be waived for the first 7 to 14 days of surgical pain, post-surgical pain, to allow physicians not to write that. In my situation in the chronic pain arena, and I think Dr. Vance and Dr. Vore and Dr. Summers would all agree, in our chronic pain arena, we check the PMP all the time, okay, because that's just a tool that we use. And all those post-surgical pain doesn't usually apply to me, although it does when I put in implant stimulators and things like that. Sometimes we don't usually give them much ventricular pain pumps, but we do have a little bit of post-surgical pain. But in that situation, it could be avoided. The other thing that bothers me, and Dr. Eastland and I've talked about this, is that we use the term a 7-day prescription. And one of the things that's been brought up to me by physicians and in several phases in the state is, well, we don't specify a pill count. And one of the things that I think we could have unintended consequences for is that I'm an orthopedic surgeon, and I'm doing a total hip on 80-year-old Ms. Jones, and she needs some hydrocodone to get over her total knee, but we don't have a pill count. So instead of, I want to get around the 7-day rule, I really only want her taking 5 milligrams of hydrocodone every 4 to 6 hours. But I can write her, up to 6 a day. But I could really write her up to 12 a day. So I could write, 12 times 7. I could write 84 pills. And I could write on there to take 2 5-milligram Norcos every 4 hours as needed for pain. I could get by with that pill count. And that falls under a 7-day rule. They put it on the prescription bottle for Ms. Jones to do this, and I've told, Mr. Smith, who's her nephew, to not give her 2 every 4 hours, but I was just writing this so that I could get around the 7-day rule. Don't really give her 2 every 4 hours because you'll kill her. And then somebody else walks in, and because it's on the pill bottle, she gets 2 every 4 hours. We fit that. She's under the 7-day rule. We've had unintended consequences because we don't specify, and we shouldn't specify pill counts. But there will be ways for physicians to get around the 7-day rule. And you say, well, physicians shouldn't do that. I can tell you it's going to happen. The other thing that's going to happen is if they happen to only write 7 days because they don't want to write a second script because they may not need it. And their prescription runs out on, instead of 7 days, they go 9 days with that 7-day prescription, and their prescription runs out on Friday night. And at 6 o'clock Friday night, they called Dr. Shelton's office because it was one of his partners that did the surgery. And Dr. Shelton's on call, and they say, Dr. Shelton, this is, Ms. Smith, and I've run out of my pain medication, what I do? Well, the only thing he can do with the Schedule II narcotic is tell them to go to the emergency room. And so I think you're going to see a lot more patients going to the emergency room for post-surgical pain, which is going to have significant increases in burden on expenses, burdens on the emergency room to see patients, and things like that. And that's all, that I was going to say about acute pain. But the chronic pain, the other problem that's going to happen with the even proposed changes is my clinic, I'm sure Dr. Vance's clinic, I don't know how many patients Dr. Summers sees for medications only, but I know Dr. Vore sees a lot. But I know in Dr. Vance's clinic, my clinic, we don't see a ton for medications only, but we do see some patients. We're getting just, the fax machine is running wide open with people, with family practice doctors trying to refer patients to us that have been on chronic narcotics for the past 2 years, and all of a sudden they're telling their patients, as soon as this law happens, we're not going to write you any more narcotics, so you need to go to Dr. McLeod's clinic. Well, we don't want those patients either. I don't want them in my clinic, and we tell them we're not going to see your patients. And I think that if we don't do some type of phase-in for getting where we want to get with this, we're going to have a whole lot of patients in drug withdrawal that are either going to the emergency rooms or they're going to, as they said, to the fentanyl and heroin. Even Dr. Hamilton, and I can tell you Dr. Hamilton is as staunch against narcotics as anybody there is. He's concerned about it. And I think we need to figure out, as my dad said, don't throw the baby out with the bathwater. Well, I didn't understand that when I was young. And now that my dad's dead and he was a physician, I understand that back in the old days, when everybody bathed in the same bathwater at the end, you couldn't see the baby because of all the dirt, and we didn't want to throw the baby out with the bathwater. And that's where it came from. But I think, and what that is an unintended consequence of the system that obviously was flawed, because we don't all bathe in the same water now. Well, we need to figure out a way to solve the opioid crisis, and I don't think we just cut the spigot off. I think that we slowly drain the tub or drain the swamp or slowly turn the spigot down, because otherwise we've got everybody in a mass panic. And if you don't believe that, come to my office and see what comes over the fax machine. And a lot of these are patients that probably should not have been treated with narcotics in the first place, but now we've got them addicted to it, and all of a sudden our answer to all of that is, well, go see a pain clinic or go see an addictionologist. There are not enough addictionologists or pain clinics in this state to deal with all of those people. Anyway, enough said on all of that. Thank y'all for your time. One last thing before we do that, and that's the chronic narcotics and benzodiazepine. There are a lot of patients with chronic opiate that have chronic pain that are also on chronic benzodiazepines by other people other than my clinic. I can tell you the number of benzodiazepine scripts I've written in 26 years probably is less than 3, certainly less than 5, because they don't have much use in the pain clinic. Okay, but they have extreme use in anxiety and psychiatric problems. And those same people are not totally exempt from chronic pain. My brother was an addict. My brother's dead in Hattiesburg, and he died from addiction. I lived addiction in my family for 35 years. And he wasn't addicted to anything. He was specific. He was addicted to whatever he could get his hands on at the time. He went to my father had the means to send him to drug treatment centers. He went to every one of them: Schick, Hazleton, the one in Nashville, Cumberland Heights. He went to Copac. He went to the one in Laurel. You name it, he had been there. And I got 1 minute, but at the same time, he required treatment sometimes with some chronic benzodiazepines to help him with his disease. He was bipolar as well, and so those patients, and sometimes even non-addictive folks, require, with chronic anxiety issues, require benzodiazepines. And if we say that you cannot put patients with chronic pain on narcotics if they're on benzodiazepines, there's going to be, the rubber's going to meet the mat, and there's going to be some problems one way or the other, either untreated chronic pain or untreated chronic anxiety issues. I do think, though, that if you're writing benzodiazepines, you should have to look at the PMP. And the only reason I believe that is because you should know if I'm writing narcotics for your patient and you're a psychiatrist writing chronic benzodiazepines, because there is an increased risk of death with the combination of benzodiazepines and opioids. But those are not necessarily mutually exclusive events. Thank you.
I was wrong. We have another speaker. We should have been on the notes. Dr. Richard Bush. Hurry up.
Won't take long. Don't want to rehash a lot of the things that everybody else has said. I'm Richard Bush, emergency physician. I'm representing myself and members of my group. We are one of the largest emergency physician private groups that are left in the state. We run 60,000 patients through our emergency department per year. It's imperative that efficiency is of utmost importance in an emergency department setting like that. On average, there's several prescriptions a day that I have to write that are narcotic pain medications. Our group does not write any more than 7 days. We don't do that just as a group as a whole. That's something that we've done and regulated ourselves. And in fact, it's not needed for most of what we see, because the things that we see that require acute pain control are going to be following those.
I think she's having a hard time hearing you.
The battery must be going. So, the acute pain situation in the emergency department, it's a bit ridiculous for me to have to look up PMP on someone who has an acute fracture. That's not, the PMP is not going to change my practice pattern. They're still going to need acute pain control in that situation. And tethering me to a computer to identify whether or not they're a chronic user or not is not going to change the management of that patient. It's going to delay care for someone who's next. So that's one thing that needs to be adjusted. I also would say that the acute pain section in this rule seems to be a bit of an add-on, because it's found in Section H under Rule 1.7, which is labeled use of controlled substances for chronic non-terminal pain. If we're going to regulate acute pain, then it needs to be like Dr. Shelton said. It needs to be its own section. It needs to have its own force, and it needs to be through various disciplines to identify what needs to be treated and what is defined as acute pain. Labeling it under the use of controlled substances for chronic non-terminal pain is not an appropriate use of these rules. The other thing that I have an issue with is the burden that it's going to place on our patients and in critical access emergency departments. I am in a metro area. I don't have problems with staffing in my emergency department, but many of the critical access hospitals in our state are staffed by out-of-state physicians. those physicians, when they start to hear the hindrances, the problems that are associated with trying to write and treat their patients, are not going to come to the state to treat, to fill those positions that we're lacking in emergency care. So you're going to have substandard care. You're going to fill those roles with mid-level providers, and you're going to fill those roles with people who are moonlighting who are not adequately trained. So you're going to decrease your care that you're giving your patients. Also, the other burden that's been identified by several people, but I think has been glossed over, is the fact that this is going to change and is going to affect the patient significantly in the amount of care that they can get, because there are some insurers that limit the prescriptions, there are some insurers that limit the visits that patients can get. And if you have a chronic pain condition that is being treated by a family physician in Indianola, who now says that this burden is too much, I can't afford an extra office staff member to look at the P&P for me to get all these regulations enforced, those people are going to be directed to a pain management center, which we've already heard is going to be long-term. Those are going to fall back onto me in the emergency department, handling care for other patients. But also, those patients are going to have to decide whether or not they want to treat their pain or their high blood pressure, because they're limited by the prescriptions that they can fill. Guess what they're going to choose? Because they've already, now they're having to see two physicians, pain management, and they're having to see their primary care physician. Because, so that means they're seeing two people whenever they could have seen one. So there's a burden there that needs to be addressed. The other question I have is, I'm not quite sure where I fall in this rule. When someone comes in with chronic pain and is on opioids, and they have a rectal abscess to that drug, that patient is going to need an increase in their pain medication. But by these rules, it seems like I would be in direct violation